Welcome to the Deep Dive. We're here to make complex topics, well, a bit less complex.
That's the plan.
Today, we're diving into supraventricular tachycardia, SVT. Basically trying to understand what's going on when the heart just starts racing out of nowhere.
Exactly. We've sifted through the guidelines, the diagnostic approaches, all that stuff.
Yeah, to pull out what you really need.
Our mission today is pretty straightforward. Give you a really solid, memorable overview of SVT, what it is, the different flavors it comes in, what might trigger it, how we spot it, and crucially, what we can actually do about it.
Think of it as your quick guide to getting totally up to speed, maybe helpful for exams too.
Definitely geared towards that, yeah. Fast and focused.
All right, let's jump in. What exactly is supraventricular tachycardia? Lay it out for us.
Okay, so simply put, SVT is just a really fast heart rhythm, but the key thing is where it starts. It kicks off above the ventricles. That supraventricular part is crucial.
Above the ventricles, got it.
Yeah, and it's kind of an umbrella term covering a few main conditions, AVNRT, AVRT, and also atrial tachycardia. But importantly, we're generally not including atrial fibrillation under this specific SVT heading for this discussion.
Okay, so AFib is separate.
Right. Usually dealt with differently. The underlying problem in SVT tends to be an electrical system, let's call it a hiccup. Either there is an issue with the signal timing creating a loop, we call that reentry.
A loop.
Yeah, or you've got a specific cell or area that just starts firing off electrical signals way too fast on its own. That's called automaticity.
So like the wiring's got a short circuit or a switch is stuck on fast.
That's a pretty good way to think about it, yeah. And the most common reasons for this, the ones we see most often, are AVNRT and AVRT. Those are the big players.
AVNRT and AVRT.
And what's interesting is how these episodes present. It can be really variable. Someone might just get a brief flutter now and then, or it could be, quite frequent, lasting minutes, or sometimes even longer.
You said AVNRT and AVRT are the main ones. Can we maybe unpack those a bit more? What makes them different?
Absolutely. Let's break it down. So both AVNRT and AVRT are types of reentrant tachycardia. Remember that loop idea?
Yeah, the electrical loop.
Exactly. Now with AVNRT, that stands for atrioventricular nodal reentrant tachycardia, the loop, the actual electrical circuit, is happening inside the AV node itself.
Okay, within the node.
Yeah. You can sort of imagine the AV node having two potential pathways for the signal, a fast one and a slow one. In AVNRT, an impulse might go down the slow pathway and then zip right back up the fast one, creating this continuous rapid cycle.
Like a little electrical racetrack just inside the node.
Precisely. And a classic sign on the ECG, often you won't see clear P waves during the tachycardia. It's just this fast, regular rhythm. That's a big clue for AVNRT.
Okay, no clear P waves. Think AVNRT. What about AVRT then?
Right, so AVRT, atrioventricular reentrant tachycardia, this one's different because it involves an extra electrical connection somewhere outside the AV node.
An extra wire.
Kind of, yeah. It's called an accessory pathway. It's like a shortcut connecting the atria and the ventricles, bypassing the normal AV node route, at least partly. The most famous type of AVRT is Wolff-Parkinson-White syndrome, or WPW.
Ah, WPW. Heard of that.
Yeah. So in WPW, the electrical signal can go down the normal AV node path, but it can also travel down this accessory pathway. This sets up the potential for that reentrant loop causing the tachycardia. And sometimes on the baseline ECG, not during the SVT, you might see a specific sign called a delta wave.
A delta wave.
It's like a slurring at the beginning of the QRS complex. It happens because that accessory pathway activates the ventricles just a fraction earlier than normal.
Okay, so AVNRT is the node's internal racetrack.
Yeah.
AVRT uses an external bypass like WPW. What was the other reentrant type?
Yes, macro-reentrant atrial tachycardia. As the name suggests, this involves a much larger electrical circuit, but this time it's contained within the atria.
Bigger loop in the atria.
Exactly. And the most common example you'll probably encounter is atrial flutter. That creates a very characteristic, organized, rapid rhythm in the atria. Often looks like a sawtooth pattern on the ECG.
Sawtooth pattern. Okay. And then you mentioned the automatic types. How do they work again?
Right, so automatic tachycardias aren't about loops or circuits. Instead, you've got a specific spot, like a rogue group of cells somewhere in the heart, that just decides to start firing off electrical impulses much faster than it should. It overrides the normal pacemaker.
Like a faulty trigger.
Exactly. So if this overly active spot is near the AV node or the bundle of His, we call it focal junctional tachycardia. If it's somewhere else in the atria, importantly, not the sinus node, which is the heart's natural pacemaker, and not the AV node, we call it focal atrial tachycardia, the signal just starts there and spreads outwards.
So it's not a loop, it's just one spot going too fast.
Mm-hmm.
Okay. What actually causes these things? What are the triggers or underlying causes, the etiology?
Well, the causes really boil down to those mechanisms we just talked about. So either setting up the conditions for those reentry circuits, like an AVNRT or AVRT, or causing that abnormal automaticity, making cells fire too quickly. Even sinus tachycardia, while usually differential, is an example of increased automaticity, though from the normal sinus node.
Right.
And there's also something called triggered activity, which is another mechanism that can lead to some tachycardias, like certain atrial tachycardias.
Gotcha. Are there specific things that make someone more likely to develop SVT? What are the risk factors?
Yeah, definitely. There are quite a few things to be aware of. Having underlying structural heart problems is a big one. Things like congenital heart defects, issues with heart valves, maybe mitral valve prolapse.
So problems with the heart structure.
Right. Also, having had previous heart surgery or, ironically, even a previous ablation procedure. Other heart conditions like coronary artery disease or inflammation like myocarditis or pericarditis, they can increase the risk too.
Okay. Anything else?
Oh, yeah. Electrolyte imbalances, particularly low potassium or magnesium, are important to check for. Stimulant use is another one, too much caffeine, nicotine, other stimulants. Stress and anxiety can actually trigger episodes in some people.
Stress. Wow.
Mm-hmm. It's also seen, maybe surprisingly, more often in younger people sometimes, depending on the type.
Mm-hmm.
And then there are things like rheumatic heart disease, chronic lung conditions, even pneumonia, and toxicity from certain drugs like digoxin.
That's quite a list.
Yeah.
So how do these factors actually, cause the heart to race? What's the pathophysiology link?
Essentially, all those risk factors can either help create those abnormal electrical pathways or make existing ones more likely to conduct improperly. For reentry, they might change the electrical properties of the heart tissue just enough to allow that circulating impulse to get going and sustain itself. For automaticity, they might make certain heart cells irritable, is one way to put it, more likely to fire off spontaneously and rapidly. So the bottom line is, SVT happens when these electrical impulses start above the ventricles but travel through the heart in an abnormal, fast way, bypassing the usual controls.
Okay, makes sense. Now, this is super important, especially for exams. Someone comes in with a really fast heart rate. How do you figure out if it is SVT and which type? What's the differential diagnosis? How do you tell it apart from other fast rhythms?
Yes, absolutely key. The ECG is your number one tool here. First thing you look at is the QRS complex. Is it narrow or wide?
Narrow or wide QRS?
Okay. Let's start with narrow QRS. If the rhythm is narrow and irregular, the top diagnosis you absolutely have to consider is atrial fibrillation. That irregularity is the giveaway.
Narrow and irregular, think AFib first. Got it.
Now, if it's narrow and regular, you need to look closely for P waves. If you can't see any clear P waves buried in there, then AVNRT is very high on your list. Remember that internal node racetrack? P waves often get lost.
Okay, narrow, regular, no key waves, likely AVNRT. What if you can see P waves?
If you see P waves, the next step is to compare the atrial rate, how fast the P waves are going, to the ventricular rate, how fast the QRS complexes are going. If the atria are clearly firing faster than the ventricles, you're likely looking at atrial flutter, maybe atrial fibrillation with a regularized response, but usually flutter with block.
Atria faster than ventricles points to flutter. Okay. What if the rates are the same and the P waves aren't faster?
Right. If the atrial rate isn't obviously faster, then you need to look at the timing relationship between the P wave and the preceding QRS. We call this the RP interval.
RP interval, right.
Okay. If you have a long RP interval, meaning the P wave is quite far after the QRS, you should think about possibilities like atrial tachycardia or maybe something called permanent junctional reentrant tachycardia or even an atypical form of AVNRT. Quick memory tip, long RP, think atypical or permanent.
Long RP, atypical or permanent? Okay.
Now, if you have a short RP interval, the P wave is really close to the QRS specifically if it's less than about 70 milliseconds. That strongly suggests typical AVNRT again. Memory tip. Short RP, often AVNRT.
Short RP, often AVNRT. That helps.
If the RP interval is short-ish, but say longer than 70 milliseconds, it gets a bit trickier. It could be AVRT, like WPW, could still be AVNRT, or it could be atrial tachycardia. There's definitely some overlap there.
Okay, so that short RP versus long RP distinction is useful, but not always definitive. What about a wide QRS complex tachycardia? That sounds more worrying.
It definitely raises the stakes. A wide QRS tachycardia could still be SVT, but maybe with an underlying bundle branch block, meaning the signal isn't conducted properly through the ventricles, widening the QRS. Or it could be SVT, where the impulse is conducted down an accessory pathway, like in WPW, which can also widen the QRS.
So SVT can cause a wide QRS sometimes.
Yes, but, and this is critical, the absolute priority, the thing you must assume until proven otherwise with a wide QRS tachycardia is ventricular tachycardia, or VT.
VT first.
Always rule out VT first. It originates in the ventricles and is potentially much more dangerous, life-threatening even. Assume wide complex tachycardia is VT, unless you have very clear evidence otherwise.
Okay, rule out VT. Very clear. How common is SVT out there in the population? What do the numbers look like, the epidemiology?
It's actually quite common. Exact numbers for the UK can be a bit fuzzy, but generally speaking, the prevalence worldwide is estimated at around 2.25 per 1,000 people.
So, fairly common.
Yeah. And the incidence, the number of new cases each year is about 35 per 100,000 people per year. Interestingly, it seems to affect women about twice as often as men.
Twice as common in women. Any idea why?
The exact reasons aren't fully clear, might be hormonal influences or differences in cardiac electrophysiology, but the observation is pretty consistent. Also, the risk definitely goes up with age. People over 65 have something like a 5 times higher risk compared to younger adults.
Okay, women and older adults more affected. What about kids?
It happens in pediatrics, too. The incidence there is roughly 1 per 1,000 children. And remember, WPW, that accounts for a significant chunk, maybe around 16% of SVT cases in kids.
Right.
But it's important to know the risk of sudden death related to WPW in childhood is actually very low, something like 0.01% per year by age 15.
That's reassuring.
It is. And just on WTW patterns on the ECG, you might see that delta wave pattern in maybe 0.15 to 0.25% of the general population. It's a bit more common if you have a first-degree relative with it. But crucially, not everyone with the ECG pattern actually develops SVT.
So seeing the pattern doesn't mean you will get tachycardia.
Exactly. And sometimes the pre-excitation, that delta wave,
Right.
can come and go. It might not be there on every single ECG.
Okay, that's a really important point. So what does it actually feel like? What are the typical symptoms someone with SVT might describe? What's the clinical picture?
Right. The classic symptom, the hallmark really, is the sudden onset of a rapid heartbeat. Patients often feel it distinctly start and stop. The heart rate usually goes above 150 beats per minute, sometimes well over 200.
Sudden racing.
Yeah. And they'll usually describe it as palpitations, that feeling of your heart racing, pounding, fluttering, skipping beats. Along with that, they might get short of breath, maybe some chest discomfort or tightness, dizziness, lightheadedness, and just feeling really tired or fatigued.
Does it very much.
Oh, definitely. The severity really depends on how fast the heart rate is, how long the episode goes on for, and critically, whether the person has any underlying heart disease. If they do, they're more likely to have more severe symptoms.
Okay.
Some people with AVNRT specifically describe this weird sensation, almost like their shirt is flapping at their neck due to the atria contracting against closed valves. Fainting or syncope is less common but can happen.
Shirt flapping. Interesting. What about the physical exam?
Well, between episodes, the exam is usually completely normal, nothing to find. But if you catch them during an episode of SVT, you'll obviously find the fast heart rate, typically regular, often between 140 and 250 beats per minute. And in some severe cases, especially if they have underlying heart issues, you might see signs of heart failure, like rapid breathing, low blood pressure, raised neck veins, maybe an extra heart sound, or crackles in the lungs.
So diagnosis often hangs on catching it in the act or getting a good history. What tests are usually done to confirm it and figure out the type?
The ECG is absolutely fundamental, as we've discussed. Capturing the rhythm during its episode is ideal for diagnosis and classification.
Right, the ECG.
If episodes are infrequent, making it hard to catch on a standard ECG, then longer-term monitoring is used. Things like a Holter monitor, which records for 24 or 48 hours, or an event monitor, which the patient activates when they feel symptoms, or even implantable loop recorders for very infrequent events.
Longer monitoring for tricky cases.
Exactly. An echocardiogram, an ultrasound of the heart, is nearly always done to look at the heart's structure and function. Check for valve problems, muscle thickness, ejection fraction, things like that. Rule out underlying structural disease.
Echo for structure. Makes sense.
And then, in certain situations, especially if ablation is being considered or the diagnosis isn't clear, an electrophysiological study, or EPS, might be done. This is more invasive. Catheters are put into the heart to map out the electrical pathways very precisely and induce the arrhythmia under controlled conditions.
EPS for detailed mapping.
Mm-hmm. And don't forget basic blood tests checking electrolytes like potassium and magnesium, thyroid function, sometimes cardiac markers if there's chest pain.
Okay. You've really hammered home the ECG. Can we just recap the absolute key ECG findings again?
Sure, it's all about classifying it. Is the QRS narrow or wide? Is the rhythm regular or irregular? Can you see key waves? If yes, what's their relationship to the QRS, that RP interval, short or long? Is there a delta wave suggesting pre-excitation, pointing towards AVRT like WPW?
Yep.
And that warning again. If you see an irregular, wide, complex tachycardia in someone known to have WPW, that's potentially atrial fibrillation conducting rapidly down the accessory pathway. That's an emergency, needs specialist input immediately.
Okay, red flag noted. When might you do some of those other tests, like the Holter or exercise test?
Right, so a 24-hour Holter, as I said, is great if episodes are frequent, but short, maybe happening daily or several times a week. An exercise ECG makes sense if the symptoms clearly come on with physical exertion.
Triggered by exercise.
Yeah. Cardiac enzymes like troponin, you'd check those if the patient has significant chest pain during an episode or if they seem unstable to rule out a heart attack. Electrolytes, thyroid tests, TFTs, full blood count, FBC, to look for anemia. Those are often done to check for underlying or contributing causes. Digoxin level if they're taking it, maybe a chest x-ray if you suspect heart failure or a lung issue. And the echo, as mentioned, is pretty standard if you suspect any structural heart disease.
Okay, quite a thorough workup potentially. So we've diagnosed it. Now the crucial part. How do we manage SVT? What do we do in the moment, and how do we prevent it coming back?
Good question. Management really splits into two parts. Stopping an acute episode, and then long-term prevention.
Acute first. Someone's heart is racing right now. What do we do?
First line, if the patient is stable, are vagal maneuvers. These are simple physical actions that stimulate the vagus nerve, which can slow down conduction through the AV node and sometimes just stop the SVT.
Vagal maneuvers. Like what?
The most common one is the Valsalva maneuver, basically bearing down as if having a bowel movement for about 10-15 seconds. Or carotid sinus massage, gently massaging the carotid artery in the neck, but you need to be careful with that. Check for bruits first. Avoid it in older patients or those with known carotid disease. Even immersing the face in ice-cold water can work sometimes. Memory tip. Stimulate the vagus nerve. Try to calm the system down.
Valsalva first.
Yeah.
But that doesn't work.
If vagal maneuvers fail, the next step for most narrow, complex, regular SVTs is intravenous adenosine, given as a rapid IV push.
Adenosine, how does that work?
It essentially blocks electrical conduction through the AV node for a very brief period, just a few seconds. This often interrupts the reentrant circuit in AVNRT or AVRT and terminates the tachycardia. Patients often feel a transient flushing, chest tightness, or shortness of breath. It's quite traumatic, but usually effective. Memory tip. Adenosine stops the node temporarily. Standard dose is 6 mg, can go up if needed.
Okay, adenosine to stop the node. What if the patient is unstable? Low blood pressure, confused?
Instability changes everything. If the patient is hemodynamically unstable because of the SVT, then the immediate treatment is synchronized electrical cardioversion. Basically, a controlled electric shock to reset the heart rhythm immediately. You don't wait for drugs in that situation.
Unstable equals cardioversion. Got it. So those are the acute fixes. What about stopping it from happening again? Prevention.
For prevention, medications are often used first. Beta blockers are a common choice. They slow the heart rate and can reduce the frequency and severity of episodes. Certain calcium channel blockers, like verapamil or diltiazem, the non-dihydropyridine ones, can also be used, particularly for AVNRT.
Beta blockers or calcium channel blockers.
Right. But for a more definitive long-term solution, especially if drugs aren't working, cause side effects, or the patient prefers not to take long-term medication, radiofrequency ablation is a key option.
Ablation. We mentioned that before.
Yeah. It's become a very common and effective treatment. An electrophysiologist uses catheters to find the exact spot causing the problem, either the slow pathway in AVNRT or the accessory pathway in AVRT, and then uses radiofrequency energy, heat basically, to destroy that tiny area of tissue and eliminate the circuit.
So ablation can potentially cure it.
For many types of SVT, yes, particularly AVNRT and AVRT, success rates are very high. It significantly improves quality of life for many patients.
What about general management? Any lifestyle things?
Definitely important to address any potential triggers. So, cutting back on excessive caffeine or alcohol, managing stress, ensuring electrolytes are balanced. The specific long-term plan really depends heavily on the exact type of SVT, how often it happens, how bad the symptoms are, and the patient's individual risk profile and preferences.
So tailored approach.
Absolutely. For AVNRT, ablation is often first line now or used if drugs fail. For AVRT WPW, referral to an EP specialist is standard, and ablation is often recommended, especially if they're deemed high risk based on EPS findings. For other types like focal atrial tachycardia, you might try different antiarrhythmic drugs like flecainide or sotalol, or consider ablation too. Multifocal atrial tachycardia is tricky, often need to treat underlying lung disease or electrolyte problems first. Maybe use verapamil long-term.
Lots of options, but ablation seems key for the common reentrant types.
Okay, shifting gears slightly, what about driving? Does having SVT affect whether someone can drive? Yes, this is a really practical and important point. There are specific DVLA guidelines. For Group 1 drivers, that's cars and motorcycles, they must stop driving if the SVT causes, or is likely to cause, sudden incapacity like dizziness or fainting.
Must stop if symptoms cause incapacity.
Right. They can usually start driving again once the cause has been identified and the SVT has been effectively treated and controlled for at least 4 weeks. They need to inform the DVLA.
4 weeks controlled for Group 1. What about lorry or bus drivers? Group 2.
Stricter rules there, as you'd expect. If SVT causes or is likely to cause incapacity, it leads to disqualification from driving Group 2 vehicles. The DVLA must be informed. To potentially get their license back, the cause needs to be identified, the SVT controlled for at least 3 months. They need to have a reasonably good heart pump function, specifically a left ventricular ejection fraction, LVEF, of 40% or more, and have no other disqualifying heart conditions.
3 months controlled, plus good heart function for Group 2.
Yeah.
Okay. When should a GP or general physician refer someone with suspected or confirmed SVT to a specialist, like an electrophysiologist, EP?
There are definitely triggers for referral. An urgent referral is warranted if the patient have had syncope, especially during exertion associated with palpitations. Also, if they present with a broad, complex tachycardia where VT is a concern, if they have clear pre-excitation, WPW, on their resting ECG, if they have known underlying structural heart disease, or if their symptoms are very severe or frequent.
So syncope, wide QRS, WPW, structural disease, severe symptoms get them seen quickly.
Exactly. A more routine referral would be appropriate if standard medications aren't controlling the SVT adequately, or if the patient is experiencing intolerable side effects from the drugs. Also, if the patient simply prefers to explore non-drug options like ablation, or if there's still some uncertainty about the exact diagnosis or type of SVT.
Okay, drug failure, side effects, patient choice, or diagnostic doubt warrants referral. What's the overall outlook? What's the prognosis like for someone with SVT?
Generally, the prognosis is really very good, especially with proper management. Most episodes can be stopped, and recurrences can often be prevented or well managed.
It's good to hear.
Yeah. The biggest factor influencing long-term prognosis is whether or not there's significant underlying structural heart disease. In people with otherwise normal hearts, the prognosis is excellent. Even with WPW syndrome, as we mentioned, the actual risk of sudden death is low overall.
You mentioned risk levels earlier.
Right. The risk is slightly higher, though still low, in WPW patients who do experience palpitations or documented SVT. It's lowest in those who just have the WPW pattern on ECG but have never had symptoms. In those asymptomatic cases, doing an EPS can sometimes help stratify their individual risks more accurately.
So, mostly good prognosis, especially without other heart problems. Are there any potential complications, things that can go wrong, even if rare?
Complications are uncommon, but they can happen. The main concern, especially in older patients or those with underlying heart disease, is hemodynamic collapse, basically. The heart beating so fast it can't pump blood effectively, leading to very low blood pressure or shock.
Okay, collapse is a risk in vulnerable patients.
Yes. There's also a small theoretical risk of blood clots forming during prolonged episodes, potentially leading to DVT or systemic embolism, although this is more associated with atrial fibrillation or flutter, usually. Very rarely, you could see complications like cardiac tamponade, usually related to procedures like ablation, heart attack, MI, worsening heart failure, syncope, or extremely rarely, sudden death.
And that specific WPW risk.
Ah, yes. The specific worry in pre-excitation, WPW, is that if the patient develops atrial fibrillation, the impulses can conduct extremely rapidly down the accessory pathway to the ventricles. This can trigger ventricular fibrillation, VFib, which is a cardiac arrest. That's the mechanism for sudden cardiac death in WPW and why identifying high-risk pathways is important.
VFib risk in WPW with AFib.
One other thing, if SVT is very frequent or almost continuous for a long time, it can actually lead to a weakening of the heart muscle, a condition called tachycardia-mediated cardiomyopathy. But this is usually reversible if the tachycardia is controlled.
Okay, that's reversible. Good. Right, let's try and wrap this up. We've covered a lot. What are the absolute must-remember key takeaways from our deep dive into SVT?
Okay, top points. SVT means fast heart rhythm starting above the ventricles. Key types are AVNRT, AVRT, including WPW, and atrial tachycardias, AFib, is usually considered separately. Diagnosis hinges on the ECG, narrow versus wide QRS, regular versus irregular, P waves, RP interval. Remember those differentials.
ECG is king?
Absolutely. Acute management involves vagal maneuvers, then IV adenosine if stable, or cardioversion if unstable. Long-term, beta blockers or calcium channel blockers might be used, but radiofrequency ablation offers a potential cure for many, especially AVNRT and AVRT.
Ablation as a definitive option.
And finally, prognosis is generally excellent, particularly in hearts that are otherwise healthy. But be aware of driving restrictions and know when to refer urgently.
Fantastic summary.
Yeah.
A really clear breakdown. And for everyone listening, if you want more high-yield revision resources like this, definitely check out pastthemsra.com and also free MSRA.com.
Absolutely. Look, understanding the ins and outs of conditions like supraventricular tachycardia is just so fundamental for good patient care and obviously for getting through those medical assessments confidently. Makes you wonder, though, what specific bit of the heart's complex electrical dance makes you want to learn more?